gonna move this here when he does your intro, and then just move it back when you're gonna talk.
Oh, I see.
Yeah.
Yeah, makes sense.
Give it like 2 more minutes and then we'll get started. Really clean up my desktop when I do these things.
There we go.
Yeah. Hey, Ram, I think we can go ahead and get started.
Okay, great. Hello, everyone. Welcome to the latest edition of What's New in Addiction Medicine. Today we have an exciting talk from Ken Lin, who is one of the fellows in the Addiction Medicine Clinical Fellowship Program based out of the Victoria site. He has a background in family medicine residency, completed family medicine residency last year in Ontario. He has a great interest in both acute and long-term care for patients with substance use. And today he's going to give us an update on endocrinopathies associated with chronic opioid use. So without further ado, thank you very much, Ken. Looking forward to your talk.
Thank you. All right, so good afternoon, everyone. And thank you, Dr. Herring, for the introduction. So today I'm presenting endocrine conditions that are related to chronic opioid use. And before we get started, I would like to acknowledge that I am a humble guest on the traditional unceded territories of the Musqueam, Squamish, and the Tsleil-Waututh nations. And I have no conflict of interest to declare today. So today we'll try to cover on how opioid can impact on certain hypothalamic-pituitary-end organ axes and how that could contribute to certain conditions. Now, of course, within such a short session, we'll not try to cover every aspect of the endocrine system, but we'll focus on those that are more related to our patient and how that may change our way of care as well. And we'll also go through some clinical presentations, diagnostic approaches, as well as managements of some of these conditions. But most importantly is to identify the current knowledge gaps that we still have from long-term opiate use and its impact on the endocrine system. So we'll start off with the hypothalamic-pituitary-gonadal axis, which I'll just use HPG from onwards. So this is a critical neuroendocrine system that regulates the reproductive function, the sexual development, and the hormone production in both males and females. It involves a feedback loop between the hypothalamus, the pituitary, and the gonads. So that would be testes in males and ovaries in females. So starting off in the hypothalamus, just a quick recap, we're looking at kind of the center part of our brain. The one that's shaded in green is hypothalamus, and the pituitary sits right underneath it. So from the hypothalamus, it secretes gonadotropin-releasing hormone, so that's the GnRH, in a pulsatile manner that travels then to the anterior pituitary gland that sits below it. Now, this pulsatility of the GnRH release is crucial. If it's like a continuous release, then it will desensitize the anterior pituitary gland, as in it will no longer respond to it. So with the pulsatile release of the GnRH, the anterior pituitary gland will then release the luteinizing hormone, LH, and follicle stimulating hormone, FSH. In males, so in the testes, the LH would stimulate the Leydig cells in the testes that is responsible for the actual testosterone production. Whereas the FSH then acts on the Sertoli cell, a different cell type, which actually is the one supporting spermatogenesis. So that is the formation and the maturation of the sperms. And that process requires the testosterone created from the Leydig cells. In females, on the other hand, the LH then triggers the thecal cells in the ovaries that triggers the ovulation and stimulates the theca cells that are responsible for the production of androgen that will get eventually converted to estrogen down the pathway. The FSH, on the other hand, then stimulates the granulosa cells, which is responsible for estradiol production and follicle development. And both hormones are responsible and regulates the menstrual cycle. All right. So over the years, what we know is that it has been shown that opioids does have an inhibitory effect on the pulsatile release of GnRH from the hypothalamus, and hence consequently impact on the secretions of the gonadotropins from the pituitary and the sex steroids from the gonads. And there is some direct evidence in terms of a direct negative action of testicular function by opioids that has been suggested, but it's currently unclear at the moment for now. And from a clinical lens, the long-term impact of opioid on the HPG axis has been relatively extensively studied, but mostly in the male population and less so in the female population. So just a brief review of what are the symptoms that we are looking for should a patient present with hypogonadism. So it will definitely have an impact on the sexual function. So decreased sex drive, erectile dysfunction for males, vaginal dryness for females, irregular menstrual cycles. Male patients may also present with development of the breast tissue or gynecomastia. But it could also impact on other aspects of the body, like fatigue, hair thinning, decrease in muscle mass, as well as osteoporosis, so the decrease in bone density. So this is a 2015 meta-analysis. So this is a study that people would do that would pull in studies that have previously done and analyze them. So they included 17 studies that covers over 2,700 participants that were examined for the association between opioid use and testosterone levels. And in this study, a wider variety of opioids and dosage forms were included. And the durations also ranges quite a lot, from 3 months to 11 years. But overall, in their study, they found that there's overall a significant reduced level of testosterone in men who are on opioids in comparison to the controls who are not exposed to any opioid. And this suppression, when they look specifically into it, is not just specific to a type of opioid. For example, methadone in this case, which is a medication that we often prescribe for opioid use disorder. And that in their sub-analyses, that although the testosterone level is shown to be a little bit lower in the methadone group, but there was no significant difference when compared to other in other opioid groups as well. And specifically, they also looked into the testosterone level in females as well. It was found not to be suppressed in the studies that examined women on opioid. So this suggests that potentially opioids, including methadone, may have different endocrine disruption mechanisms in both men and women that we are still currently unclear about. That's not my cursor. Okay. So there's a later retrospective cohort study done in 2019. Close to 1,200 men were included who are on long-acting opioids for chronic pain in comparison to those who are on shorter-acting hydrocodone. And the morning serum total testosterone level were also measured in these subjects. And they were only selected for those who are only on a single type of opioid. So there's no mixing of opioid in their studies. And just to see if there's any association between the two. So androgen deficiency, so the lack of testosterone, was also noted in those who are specifically using methadone and fentanyl, which are 52 and 69% respectively, versus the shorter, those who are on short-acting hydrocodone, about 34%. And there was also a higher odds ratio of having androgen deficiency in these two groups, about 26 to 7% respectively. Now, you might notice the confidence interval is a little bit high or quite wide for the fentanyl group. The only reason is because the sample size was actually very small in this study. And they also want to look at if it's actually related to the dose then. So they measured or they calculated the effective dose of every 10 milligrams more morphine equivalent of dose increase. And they did not see any statistically difference in terms of the opioids, except for the control group, those who are on hydrocodone. But once again, the confidence interval is relatively close to 1 as well. And it's just to overall show that currently there hasn't been a specific findings related to a dose response pattern that we are observing. Now we have been looking at 2 studies that focus on men. There are actually much fewer studies that looked at female populations in terms of opioid impact on the HPG axis or the hypothalamic-pituitary-ovarian axis. This is a small study that I found that looked at a group of 47 women taking sustained action oral or transdermal opioids. So that could be methadone, that could be sustained release morphine or fentanyl patches for non-malignant pain. And this was compared to controls who were women in the communities with no exposure to opioids. And indeed, hormone suppression was observed. Those who were on opioid treatment had about 48 to 57% lower levels of testosterone and estradiol in comparison to the controls. And that is statistically significant as well. In terms of the LH and FSH, so that was the hormones coming directly from the pituitary gland. It was shown also to be significantly lower by 70%, but only in the postmenopausal individuals in this study. And in terms of menstrual effects, among the women under 50, age of 50, about 52% of the participants on opioid had amenorrhea, so the pulsation of their periods, versus 20% in the control group. And many also reported cessation of their periods shortly after starting the opioids as well. And secondarily, the majority of them also reported that they have associated symptoms of fatigue, low libido, and depressed mood as well. So now that we have overall showed a decreased levels of sex hormones while on opioid, do we really see them as having any direct associations of hypogonadism, especially those we're treating with opioids? So this is an earlier meta-analysis done by Yi et al. Back in 2014 that evaluated the prevalence of sexual dysfunction among male patients with opioid use disorder who are on either methadone maintenance treatment or buprenorphine maintenance treatment. So both of these are common medications, synthetic opioids that we prescribe for opioid use disorder. In total, there were about 16 studies that were included. And when they pull in the data, the prevalence of sexual dysfunction was estimated to be 52% among the methadone group and 24% in the buprenorphine group. And out of those 16 studies, only 4 of them actually compared them head to head. And the methadone group was shown to be having significantly higher combined odds of having sexual dysfunction than those who were on buprenorphine. But the one thing to note that in this study is their definition of sexual dysfunction, because they kind of have a very broad inclusive criteria where they include those that looked at erectile dysfunction, low sex drive, orgasmic function, etc., and all into their study. So it's a relatively broad definition when they were conducting the meta-analyses. So actually the same group of author then looked at to see whether exactly if there's any association between this lower level of hormones that they found are associated with sexual dysfunction. So they did a study where they compared once again, men on maintenance therapy treatments of methadone or buprenorphine and measured their plasma testosterone and sex function. And there were a total of 76 men that were on the in the methadone group versus 31 men in the buprenorphine group. About 41% of men who were on methadone had a total testosterone level that was lower than the reference range. So not just a trend, but actually lower than the reference range. Whereas about only 1/5 of the men who were on buprenorphine did. And the plasma testosterone level was also shown to be significantly lower in the methadone group in comparison to the buprenorphine group. And when they conducted the survey on sexual dysfunction, the methadone group also scored significantly lower in terms of sexual desire on the survey in comparison to the buprenorphine group. But other aspects covered by the survey, so for example, erectile dysfunction, orgasmic function, intercourse satisfaction, were all shown to be lower in the methadone group, but they were not significant in their analyses. And another thing about this study is that there's no comparison to a control group without any exposure to opioid as well, or a non-treatment group. So we kind of talked a lot about her hormone levels by this point already. So I just want to do a quick summary of what we have covered. So overall, it has been shown that there is an impact on the HPG axis by long-term use of opioid. Testosterone in men specifically have noted to be decreased, and that there may be some differences between opioids, but that needs further studies at this point. And there is actually very few studies that looked at the impact on the ovarian axis in women in the female population. So since we're talking about hormone deficiency here, there are management options for them, including discontinuation or reduction of the drug dose, say the opioid that we're prescribing. And if that is not feasible, then to consider providing a gonadal hormone replacement. And specifically, we're talking about testosterone replacement for men. But currently, there's no long-term studies that evaluates the safety of testosterone replacement therapy for these patients specifically, as well as the long-term outcomes and their end goals as well. And in terms of hormone replacement therapies for women has actually not yet been studied for opioid-induced hypogonadism. So currently, there's no recommendations for hormone replacement therapy from that aspect. And since we're talking about it, we're just going to quickly touch on testosterone replacement therapy. So according to our local Canadian Urology Association guideline, they defined a low testosterone level, so testosterone deficiency, as anyone who's presenting a combination of clinical symptoms plus a low level of total testosterone. And their level of low total testosterone really means that either it's lower than the normal reference range or less than a level of 10 nanomoles per liter, which is a reasonable threshold from their perspective for diagnosis, if the patient is presenting with symptoms, that is. And treatments and option endpoints are included in their guideline, but the overall aim is to use the minimal dose to help relieve the symptoms and increase the level of testosterone. So there's no specific endpoints or cutoff that we're trying to reach for. And here's just like a list of available treatments that we have here in Canada and their dosage. So now we'll just move on to our next axis. This is the hypothalamic-pituitary-adrenal axis. So the adrenal glands, which we all have two, that sits right on top of our kidneys, they are responsible for the production of cortisol. So cortisol is a hormone that is released by our body in response to stress. So it regulates the body's use of sugars, fat and protein for energy. It also regulates our blood pressure and our cardiovascular function. It also plays a role in regulating our sleep patterns as well. And so the HPA axis regulates the cortisol production in response to things like light, to stress, and the timing of the day. And the results of this regulation is quite robust. A circadian rhythm, so a 24-hour cycle, where you see that it will peak in the morning, the first thing when we wake up, and it will decrease throughout the day and reach its lowest point by night when we're asleep. And so when we looked at earlier studies in terms of opioids' impact on this axis, the animal models were actually not very representative of the human bodies. So if we look specifically at the most recent human studies, they all kind of suggest that long-term administration of opioids do have an overall suppression on the HPA axis. And this is mainly because that we found receptors of opioids along in the two main structures, both the hypothalamus and the pituitary gland, that the opioids can actually act on, whether that's the endogenous opioid or the opioids that patients receive. So as a result, when the cortisol production is suppressed by the opioid, or what we call an opioid-induced adrenal insufficiency, or OIAI, patients can have symptoms include fatigue, nausea, vomiting, weight loss, dizziness, or muscle aches, and many of which, as you could see, really overlaps or compound on the symptoms that are related to opioid use or other conditions that require long-term opioid treatments, for example, chronic pain syndrome. So this issue may actually in turn then interfere with our process of diagnosis or generating a care plan for our patients, right? Is the fatigue, for example, coming from the opioids that we're prescribing, or are they just in withdrawal when they're experiencing the nausea and vomiting? Or does the picture is really just painting an underlying lack of cortisol for our patient? So given that most of us would encounter patients who are on long-term opioid exposure, whether that's opioid use disorder or opioid treatments, it is important for us to kind of recognize OIAI as a differential that we need to keep in mind when we're providing care to our patients. So, and before we actually even dive into talking more about OIAI, we do need to note that the current diagnostic approach actually remains quite elusive at the moment, because all the available data that we could collect are either really small placebo-controlled trials, some retrospective studies, but mostly are just case reports. And they are all based on different opioid formulations and dosage and frequency. And on top of that, all the investigations for adrenal insufficiency in the first place has not been quite consistent across the world as well. So this makes the interpretations or the comparisons of a lot of our test results to be quite difficult and sometimes quite unsatisfying, because we can't really draw a firm conclusion from them. So for example, when we look at the prevalence rate of OIAI that was quoted by a recent review study, was reported to be around somewhere between 9 to 29%. And this is once again simply due to the variation of the studies that are available in the literature. And specific risk factors for the development of OIAI have not yet been identified or systemically studied. So we only got pieces of evidence here and there that we're trying to pull together. So just to demonstrate this is a study done by Lee et al. Who looked at those who are on long-term opioid treatment for chronic pain. And they have already been diagnosed with OIAI as well. And they found that the majority of them presented with symptoms that are related to both the OIAI as well as chronic pain, and that some of these symptoms did indeed improve with adrenal insufficiency treatment. So this just shows that once again, that the diagnosis can be quite hard to make. It could be easily missed or be delayed. So we'll start off by actually looking at a case that was reported, that was suspected to be OIAI. This is a 33-year-old male with opioid use disorder on buprenorphine, 16 milligram. He was reported to be in remission by this point. And he initially presented to the hospital with this significant GI bleed that he was admitted to the ICU for. But following the stabilization for the next few days, the patient persisted to develop recurrent hypotension that was refractory to any fluid resuscitation. And so if you're like the medical student or the resident, you're like, well, could this be OIAI? So you try to search up and up to date, and which I kind of borrow their flow chart there, which kind of summarize all the most recent guidelines or recommendations, whether that's like the task force or the European Endocrine Society. They all kind of recommended a general approach, starting off with testing the level of the morning cortisol as kind of the first line diagnostic approach. And if that is low, then you could see that adrenal insufficiency is probably likely. But if the result is inconclusive, then you can proceed with this ACTH stimulation test. That is when we provide an ACTH analog, the signal coming from above, to hopefully elicit a response, a rise of the cortisol level. And we measure it at about the 30-minute and the 60-minute mark. However, though, these recommendations are mainly applied to primary adrenal insufficiency and does not specifically address our case with patients receiving chronic opioid therapy, which we know is actually affecting both the hypothalamus and the pituitary gland, or most likely to be affecting those two glands. So when I looked into the literature currently, there are indeed multiple recommendations available. Overall, they would say that for patients who are presenting with symptoms suggestive of adrenal insufficiency due to opioid exposure, they would still recommend doing a baseline cortisol as well as an ACTH stimulation test with similar cutoffs as before, but they would suggest checking on other components along that pathway as well, just so that we can narrow our diagnosis onto OIAI. So I'm just using the one on your left for it as an example. This is relatively recent, published in 2018 by Dungan and Bengals et al. In I think it was Mayo Clinic Proceedings that they published on, which they suggested a slightly looser cutoff for the morning cortisol. This is, by the way, the American unit, so I have the reference range down below. And on top, they would also recommend testing the actual ACTH level itself, in addition to DHEAS. So DHEAS is a weak adrenal and androgen hormone that's also produced by the adrenal gland responding to ACTH stimulation. And so if these levels are all low, then we could then most likely say that there is indeed adrenal insufficiency and that it might be related to opioid use. And if that's still inconclusive, then they would recommend doing a stimulation test. And on top of that, knowing that if opioids is only affecting the axis from the top, like the hypothalamus and the pituitary gland, then we should also expect that other hormones produced by the adrenal glands should not be affected, like, for example, the mineralocorticoids. And that would, again, help us to confirm the diagnosis of OIAI. So now we're going back to our original case, our patient with this recurrent hypotension. So the medical team that reported this case said that they did indeed conduct a comprehensive evaluation just to rule out the common etiologies, like, for example, septic shock or high hypothyroidism. And they also make sure that the patient was indeed afebrile without any tachycardia, his vitals were stable, chest x-ray was negative, echo was negative as well. And so with the persistent high hypotension, they suspect that it could be related to adrenal insufficiency. And so they measured the morning cortisol as well as the ACTH stimulation test. And indeed, they all returned to be suboptimal. And they took one next step is by doing a imaging just to make sure that there's no structural changes to the pituitary or the adrenal glands themselves. And so now that they have this on their differential, they considered by doing a trial of treatment. So the steps that they took is, number one, they would try to discontinue the culprit medication, which is the buprenorphine in this case, and they initiated the patient on hydrocortisone therapy. And just to kind of review our treatments for adrenal insufficiency in general, which is the same for both opioid-induced and not, is that our goal is to eliminate the symptoms that are related to the lack of cortisone. So we're going to achieve this by providing a replacement of the cortisol, but also at the same time trying to mimic that physiological pattern that I previously described. So we'll usually give it at a divided dose, with the first dose in the morning being the highest. And the most commonly medication that we use is hydrocortisone. And of course, there's also times where if in terms of a higher demand, as in like response to stress, for example, a sick day, then we can adjust the dose accordingly. And so in their case, following the discontinuation of the buprenorphine, the patient was also simultaneously started on hydrocortisone. And with the introduction of the hydrocortisone, as expected, the blood pressure normalized. However, though, they weren't unable to provide any further follow-ups to look at the outcomes as the patient left AMA for them, which I suspect is because, well, they discontinued the buprenorphine for the patient. Now, similarly, another case that was also reported down in the States is this 40-year-old lady who is also stabilized on methadone while she was admitted for bacteremia, so infection. And following the resolution of her infection, the patient was actually still experiencing this persistent low sodium level as well as lightheadedness. And so for whatever reason, they jumped straight to an ACTH stimulation test, which actually come back to be kind of within the normal range. However, though, several weeks later, when they were doing follow-up, the patients persisted to have similar symptoms of lightheadedness as well as mild hypotension and hyponatremia. And so this is where they start to suspect that this is indeed adrenal insufficiency. And so they did the test as kind of what we saw previously, that they tested the morning cortisol, they did the ACTH level and the DHEAS level, and all three of them were shown to be low. And so immediately they started her on supplemental steroid therapy as well. The only thing in their study is that they did not mention whether they stopped the methadone for her or not, or whether they did a reduction of dose. And nor did they report the follow-up outcome result from that point onward as well. So in summary, just to kind of quickly recap in terms of what we have already discussed today, there's actually no consensus in terms of the diagnostic approach for OIAI. And the symptoms that are presented with OIAI are actually often quite nonspecific and even overlapping with a lot of opioid-related conditions. But at least we know that it is often associated with a low cortisol level, a low ACTH level, and a low DHEAS level, and that often there may be associated suppressed cortisol response when we do a stimulation test. So we could do the tests for these corresponding levels to help us with diagnosing OIAI. And we also talked about the treatment as well, which may by itself a main barrier, as it's recommended to either discontinue or reduce the dose of opioid and to start them on cortisol replacement therapy. So we're just gonna quickly cover the last axis of the day. I'm trying not to make this like an endocrine lecture for you guys. But since we're talking about, patients presenting with general non-specific symptoms like fatigue and weakness, often hypothyroidism would come into mind. And that is indeed something that has been looked into as well. Just like kind of in our previous first case with our young man presenting with methadone, they also checked his thyroid level as well. So just a few a background about thyroid, the thyroid axis. The thyroid gland is located right at the bottom of our neck that produces the hormone that regulates our metabolism, our growth, and energy expenditure. And key components along the pathway is very similar to the previous two. We have the hypothalamus that releases thyroid-releasing hormone that gets to the pituitary to stimulate the release of thyroid-stimulating hormone, which is actually the marker that we often measure. This then, in turn, stimulates the thyroid to produce and reduce the actual thyroid hormone T3 and T4. And when we do have a altered level of thyroid hormones, we may experience different types of symptoms. When we have too much or hyperthyroidism, we would often have an increase in terms of our baseline metabolism. So that could lead to weight loss, they could lead to heat intolerance, weakness, fast heart rate, sometimes or arrhythmia as well, and disrupting our menstrual cycle, as well as causing insomnia. Likewise, when we have a low level of thyroid hormones, we could also, our metabolism is then being cranked down. We would experience fatigue, weakness, cold intolerance. Our body is now in this energy saving mode where we may experience weight gain, a slowdown of our bowel movement, leading to constipation, as well as muscle aches and irregular menstrual periods as well as a depressed mood. So based on most animal studies, we have observed that opioids actually have an inhibitory effect on the TSH secretion. And but when we looked at human studies, as in this review, our article that reviewed, I believe it was seven studies of over 200 patients, and they described that the effects of opioids on the thyroid axis only showed that, I think there was only one study that showed that the TSH level was actually higher immediately after the administration of morphine in comparison to before. However, though, overall, in terms of chronic use of opioid, it was not associated with any thyroid dysfunction. And so that was done in 2020. So I tried to look for any new studies later on. This was a cross-sectional study that was based on a cohort study that was run in Iran, where they included over 700 participants, where they were divided into the opioid use disorder group that were either still using opioid or on treatment in comparison to controls who have no exposure to opioid. And they did note that the TSH level was actually higher in the OUD group in comparison to the control. But when they did their sub-analyses, this was actually only being noticed in women, but not in men, and which women contributed about 25% of that group. And when they look further down at the T4 and T3 levels, in the OUD group, it was also shown to be significantly lower in terms of T4, but not quite so in terms of T3. But overall, this is once again only a cross-sectional study, and that they are only looking at the general trend. So we're not looking actually at the diagnostic level of the thyroid. It's just showing that the levels could be either high or low in comparison to the control group. So there was another study then that was also done recently, which is now using a case series method where they followed about 270 cases that looked at those with OUD that are on methadone versus those that are not. And they were able to compare the TSH, the T3s, and T4 levels in those two groups. And the average levels of these three hormones were actually shown to be higher in the methadone group, once again, than the control. But the difference was only significant in terms of the TSH. And once again, this is only looking at the actual level, but not the actual diagnostic rate of hyper or hypothyroidism in this case. And so with that study, they took one step further. They say, well, how about for those who are actually receiving methadone? Is there actually a dose-related response or association, I should say? So they looked at those who are receiving only less than 100, those who are over 150, and those that are in between. But once again, they were unable to find any significant difference in all three levels for this study population. So overall, in summary, is that there's actually overall no evidence showing thyroid dysfunction is associated with chronic opioid use. And to kind of jump to the conclusion and the takeaways of today is that number one, that opioid-induced endocrine conditions can be easily missed just given the general, the non-specific and overlapping symptoms that patients with opioid use could already present it with. And hypogonadism secondary to opioid use and its related sexual dysfunction are relatively common and observed specifically in the male populations that are more extensively studied. In terms of chronic use of various types of opioids have also been shown to be associated with the suppression of the hypothalamic-pituitary-adrenal axis, leading to OIAI. But there's no overall universal diagnostic approach for that condition. And that the management of a lot of these opioid-induced and endocrine conditions, whether that's hypogonadism or OIAI, may involve the tapering or the discontinuation of opiate therapy and initiating hormone replacement if appropriate. But that being said, there's no studies that have been really further investigated in terms of how the outcomes are like. In terms of evidence, and evidence associated with thyroid dysfunction, like I said previously, has not really been shown with the current literature. But overall, there's still quite a lot of room for research that is required to look into the long-term impact of opioid on our endocrine system, especially coming up with diagnostic approach and looking at different patient populations. So those are my references, and thank you.
Great. Thank you. Thank you very much, Ken. That was a great talk, really interesting. And lots of things definitely come out of that for those of us who do much addiction medicine practice. So we have a few minutes for questions, which is great. I would encourage anyone who can to unmute and put their video on so we can have a little bit of discussion here. And I see one initial question here from Karen. Please go ahead, Karen.
Yes, hi. Great talk. I'm an addiction doctor, but I also do pain medicine at Vancouver General now. And I was struck by the fact I don't see people with opioid use disorder very often using cannabis, but I see a lot of people with chronic pain and long-term opioid therapy using cannabis. And I can imagine OIAI gets, the symptoms can get also mixed up with cannabis hyperemesis, because we see these people who have not just emergency visits with their vomiting, but also this grumbling nausea and abdominal pain. You answered my question. I guess there's no studies showing that tapering reverses that. Did I understand that correctly? There's no...
Like recommendations have been made, but in terms of actual studies, those have not yet been done.
I think it really highlights how trauma, which I think underlies a lot of what we see as pain and addiction, triggers addiction, triggers medical issues like this. And then, of course, the treatments are going to, the hydrocortisone is going to make, I imagine, is there evidence around osteoporosis being increased as well in patients on?
Yes, I think that is indeed an area of interest of research that I did not look into. But if I recall correctly, there are in these studies that looked into decrease in bone density as a consequence of low testosterone level.
Yeah, so as our patients are surviving the opioid crisis, that's going to be the next thing on the list of all the multiple issues we see them with. And is there something in here also that's related to the increased risk of infection, which I've read about, but I don't know what the pathophysiology is. And I certainly see my patients on opioids with poor healing and grumbling infections.
That I have not encountered during my research, but potentially, yes. We're not sure about. Yeah, I'm not too sure about that part.
Super interesting talk. Thank you so much. And I appreciated how I eventually got invited here because I'm not on the island. Thanks.
Great, thanks. Thanks, Karen, for the question. Any other questions that anyone has related to this talk or?
Shane from Pax here.
I have like 1,000 questions. I can keep going. So I think so. That was I think a really underappreciated topic. Thanks for the deep dive. I'll start with the so I'm struck by some of the early studies you talked about differences in testosterone levels between patients who were on buprenorphine versus methadone. So do you know in any of the studies, were they accounting for sort of treatment history and duration of time on opioids?
Correct.
Or was it just kind of like a single snapshot? Because
They are
different patients.
Right. For the meta-analyses that I looked, or not the meta-analysis, but the cohort study where they compared it to two groups, I think the duration was only a minimum of 8 weeks. So it's actually very short from that perspective.
So
like
it doesn't compare like people's like past treatment.
Exactly, nothing from that perspective. Yeah.
So I mean, oftentimes I think switching to a partial agonist is suggested as maybe
Exactly, right.
It really is like
right.
Pretty
But even like for such a short duration, we were already seeing the difference already between
right.
the two.
I guess the question is if there was more profound suppression in the methadone patients, but especially in the US, methadone patients are typically a more severe subset. They just have like a longer history over time of opioid exposure.
Totally, yeah.
So we
don't really know exactly. Yeah.
I have more questions, but I'll go again.
Yeah.
So I mean, I'm also struck by the pretty high prevalence of adrenal suppression, and the fact that I've spent a lot of time working in an acute, like an inpatient consult team. We never talked about this. Should we be, and people who are critically unwell, should we be considering like empiric hydrocortisone, or is there any conversations around that? Does anyone here even look or suggest we should be looking at opioid-induced adrenal insufficiency or partial insufficiency in patients you see, which is kind of well, this is not something I tend to think as an interest. Probably shouldn't.
And it's kind of like their one point of access that now they're in the hospital. We could do all those testings done here in the inpatient setting as well.
Hard to test, isn't it? Just setting the acute illness, but is there any context where we should be treating empirically in ICU patients, for instance?
Right.
Bacteremia, should we be
putting them on?
Is you come across anything?
Not from them. Yeah, from the case. Yeah, from the case reports, not yet. Yeah.
Again, for the great talk. I was kind of along the lines of asking the question, like, based on your research, do you think there's any indication for us to proactively monitor for people's like hormone levels to address issues before they maybe become more symptomatic? Because again, this is not something that we think of.
Oh, totally, yeah, for sure. Honestly, from my limited experience, I don't think I do know much about that aspect. I have been seeing that on, like, for example, patients in outpatient clinics, like OAT clinics, that I have seen patients that have been started on testosterone replacement therapy as a way to kind of mitigate their symptoms, not just coming directly from the opioids. So from that end, yes, I have. But in terms of like how commonly should we be doing it? Is there any structural or any like recommendations that we should follow? Not quite so. Well, we can go for it.
Just wondering, if you came across any impacts on pancreas or opioid.
Oh, that I have not. No. Yeah. Is there something in your mind that you're thinking about?
Just curious.
Oh, I see. Great. Because it is it is part of the endocrine system as well. Go ahead.
perspective, if you're like in reference to like doses that people were prescribed,
Mhm.
and if that was the only opiate they were using, or if it were still
Right.
like unprescribed use.
Totally, yeah. From the testosterone studies that was done, those were done in Malaysia. I don't think they take one step further in terms of evaluating if there's a dose response to it as well. In terms of OIAI, I think there's even fewer studies based on those as well. So you could see that there's still lots of like gaps that we have for this. Oh, and there was a message.
Just to say questions about.
Oh, I see. Yes. Sorry about that. We were just talking about whether the last questions was there any dose response in terms of when we're comparing the buprenorphine versus the methadone group on their impact on the testosterone level? And the answer is currently we don't have any research done related to that.
Did you come across any prospective trials where they're supplementing people over time, with testosterone or hydrocortisone, anything?
I don't think
Does it
we
have
did.
data?
I don't think so, but potentially should.
I have a question, Ken.
Oh yeah.
I think you sort of addressed screening for particularly hypogonadism.
Mm-hmm.
That there isn't any specific guidelines. Do you think in your talk you can just go back to the slides on hypogonadism, particularly with women?
Absolutely.
And so for men, there isn't any guidelines that I've seen, and I'd love for you to correct me if I'm wrong around when to test for hypogonadism and how to decide if you should test other than just symptoms, people complaining of specific symptoms. I've really had a tough time determining how much proactively I should be going out and asking people for if they're having symptoms in men versus just waiting for them to come to me. Because I think probably if you would ask people, a lot of people would say, yes, they have symptoms and maybe some of the symptoms are a little bit vague. But if you go to, you had a slide specifically on some different trials with women.
Mm-hmm.
With estrogen, and if you go back a few slides, oh yeah, maybe.
Those are, sorry, there should be this.
And so obviously the research has really not analyzed enough women sort of with hypogonadism or suspected. And in men, it's a little bit more straightforward. If they have low testosterone, you replace testosterone potentially if they're having symptoms as well. But as based on the limited amounts of research and your knowledge, what would you suggest for women in terms of particularly if women are having symptoms?
Right. So to my understanding for hormonal replacement for women specifically, my understanding has always been limited or centered around post or perimenopausal care. And beyond that setting, I don't think I know too much about any other specific guidelines or screenings for her hormone replacement from that perspective. So should a patient with opioid exposure, whether that's from OUD or treatments, at this point, testing for the levels, if it doesn't result in any treatment, like change in terms of treatment plans, I don't think that there would be any like firm recommendations of things that we should do in terms of investigations. But that's what I would say. But if anyone else have any other thoughts or recommendations from that perspective.
Yeah, I'm interested to know if anyone in the audience with experience in this area has ever considered any kind of treatment, particularly for women with symptoms that may be related to this, and like if they have if they're premenopausal and they have suppressed total testosterone, estradiol.
Because like one thing that the research has not yet pointed out or studied is actually to assess the fertility rate as well, because that may be a concern for our younger population, both for male and female as well.
Okay, thank you, I guess. No one has any particular experience. It's definitely an area where a lot more research is needed, I think. Any last questions that anyone would like from Zoom, or Ken, if you can see anyone there in the live audience? Any last questions? Hearing none, Ken, thank you very much for a great talk. Really important area that's I think a lot of us think about occasionally, but don't get a chance to just really focus on it and get a good review of the literature. So thanks so much for that. I hope everyone has a great rest of their day. And there's a survey. Encourage everyone to complete the survey who's on Zoom, or I'm sure the in-person people will get it in an email. Great. Anything else, Raman?
No, that's all. Thanks, everybody.
Okay, thanks a lot.
Bye.